Good afternoon, everyone. First of all, we would like to welcome each one of you to this important session or a session in which we thought of bringing all the people who have presented at ISBT Gothenburg so that their work can be seen or heard by others who could not be there due to various other issues. So for chairing this important session, we have our national faculty, Dr. Suro Sangha Datta. He is a consultant and faculty in charge in transfusion medicine at Tata Medical Center. He did his MBBS from North Bengal Medical College and MD from Government Hospital Kolkata, and following which he did a fellowship in transfusion medicine in Tata Medical Center. He has got various awards: the Harold Gunson Fellowship Award in 2021, the H.D. Shuri Award in 2021, the V.A. Punnus Young Scientist Award in 2020, and Professor J.B. Chatterjee Centenary Celebration Ceremony Award also. And he's a member of ISBT, and he also has been awarded an exempt membership from ISBT. He's a life member of ISTM, ISBTI. He's also a reviewer of various national and international journals. His major scientific interests or fields of interest include immunohematology, fatal serology and functions, clinical hemotherapy, and evidence-based transfusion practices. He has a lot number of publications, that is around 45. He has around 8 funded projects also, in which he's PI and co-PI, and various conference abstract papers. I invite Dr. Subro to chair this session and take the session forward, and introducing our next two speakers.
Am I audible?
Yes, sir.
Okay. Thanks, Rafi, and thanks for the kind invitation. It's a pleasure to introduce our speakers for this particular event. So our first speaker will be Dr. Jashashi, and she is currently an assistant professor in the Department of ISBT in Himalayan Institute of Medical Science in Dehradun. She has done her MD in transfusion medicine from PGI Chandigarh, followed by the senior residency from AIIMS New Delhi. She has multiple awards and the travel grants, and she is also a co-chair in patient blood management subgroup of Clinical Transfusion Working Party of ISBT. She has 25 publications, among them 22 are in the international journals. So welcome, Dr. Jashashi. And our second speaker, can I have the slides for the second speaker? So our second speaker is Dr. Deep. So Dr. Deep is currently senior resident in the ISBT department in Kasturba Medical College, Manipal. He has done his MD from TMH Mumbai, followed by the DNB with a gold medal, and cleared the Part 1 FRC path in transfusion sciences last year. He also got multiple awards and the research grant from the ISBT, including a ISBT I Tried 2020 program of 5,000 euro, and got a few first prize in the quiz as well as in the national conferences. So welcome, Dr. Deep. So we'll take the questions at the end of the session, and I would request Dr. Jashashi to start the session.
Thank you, Doctor. Am I audible? Hello?
Yes, yes.
Am I audible? Okay.
Yes, yes.
Thank you, sir, for your kind introduction. I'm just honored to be here. I'll just share my slides first. Is my screen visible?
Yes, kindly go ahead.
Okay. So very good afternoon to everyone who's attended, who's joined the meeting, and I'm very thankful for the Transfusion Medicine Academic Society for its initiative and inviting us to present our work here. So today I'll be discussing the H-deficient phenotypes, which we all know serves as a broad umbrella under which the Bombay and the para-Bombay blood group is basically comes under. So just to give you a slight introduction before just venturing into the slides, I'll just give you a brief introduction of our Rh deficient phenotypes and then move forward. To give you the overview, we'll start with a brief introduction, then the background of the case that we had, then casework at the department of our department, the discussion that follows, and the take-home message. So as we all know that our RBCs consist of antigens. And to start with the H antigen, the RBCs consist of this precursor type 2 chain, which consists of this galactose N-acetylglucosamine, galactose and glucose molecule, which when acted upon by this H gene product, which is this enzyme, L-fucosyl transferase, it is a glycosyl transferase enzyme. This precursor chain, when is acted upon by this enzyme, leads to this addition of this fucose molecule onto this precursor molecule, which leads to the formation of this H antigen. Now, please remember that this H antigen is the one that is the precursor for formation of A and B antigen, and it is mandatory to be there if you have to, turn into A or B antigens. So moving forward, this antigen, when acted upon by the product of this B gene, which is D-galactosyl transferase, it leads to the addition of this D-galactose onto this precursor molecule, which leads to the formation of B antigen. And as we all know that B antigen when present on the RBCs refers to the B blood group of that individual. Similarly, when this H antigen is acted upon by the A gene, when this is acted upon by this A gene, under the effect of this enzyme, this H antigen will be converted into A antigen. Just a second, I'll have to minimize the participants is coming on my screen. Please excuse me for a moment. All right. So sorry for the interruption. So H antigen being a mandatory molecule when acted upon by the product of this A gene, which is this N-acetylgalactosamine transferase, it leads to the addition of this immunodominant sugar. When this immunodominant sugar is added upon this H antigen, it leads to the formation of A antigen, and the blood group comes as A blood group. So as being transfusion medicine experts, we all know this, we are aware of this. So what we need to remember for now is that H antigen is mandatory for the formation of A and B and AB blood group. And as these blood groups are formed, the concentration of H antigen keeps decreasing while we are forming the AB and AB antigens. Now, what is the relevance? Now, what happens if this H gene or FUT1 gene gets mutated? When this gene gets mutated, no enzyme is formed. When this no enzyme is formed, this precursor molecule remains unchanged, which unchanged precursor molecule, when no fucose is added, leads to the Bombay blood type. So now we all know that an H deficient phenotype, it is called so because this gene is defective and the H antigen is not formed. It is just the precursor chain which is present on the RBCs, which leads to the Bombay phenotype in this individual. So this is the RBCs regarding the RBCs of a Bombay phenotype. Now we also know that in addition to the RBCs, our secretions also contain substances. My screen isn't moving. Is there some issue? Am I audible?
Yes, you are audible.
But my screen. Okay, so moving forward, now this H and ABO substances are also present in our secretions. These secretions are basically our secretory glands. Like we know that in saliva, in tears, in amniotic fluid, and our sweat. All these secretions consist of these ABO substances. What is the difference? The difference is that here there was precursor chain type 2, whereas and in secretions we have the precursor chain type 1. And what other thing changes is the gene. There we had the H gene and now we have the secretor gene, that is the FUT2 gene. So the difference between the two is the precursor chain and the gene which is involved. Rest everything else is same. You'll see the enzymes are same, the products are same, and they are called as the substances within this secretions when they are present in the secretions of plasma. So moving forward, why is it important? This is important because our Bombay phenotype lacks the secretor gene also. So the Bombay phenotype, in addition to lacking the H, in addition to mutation in the H gene, this also lacks the secretor gene. So there is no ABO substances in the secretion. There is no HAB substance A antigens on the RBCs. So it's a very poor fellow basically. So now we have already spoken about the antigens on the RBCs. Moving forward to the antibodies. Antibodies, there is a golden rule to follow. It says that whatever antigen is present in our red cells or in our body anywhere, our body will not develop antibodies against them. Our body will develop antibodies either against mutated antigens, the antigens absent from our body, or foreign exposure to some antigen. So this is a golden rule to be followed. Keeping all these things in mind, moving forward, we have two H deficient phenotypes, which is defined as, these are the phenotypes which completely lack the H antigen on the RBCs due to a mutation in the H gene. Regarding the Bombay phenotype, we all know, just to give you a slide, it was discovered in 1952 by Dr. H.M. Hende, and it was basically present in 1 in 10,000 individuals in India alone. Whereas Bombay as a phenotype is present in 4 in per 1 million population of the world. Moving forward, in a para-Bombay differs from Bombay in some aspects. Mutation is present here also. On the RBCs, it doesn't have a H antigen, it doesn't have a AB antigens at all, but it is a secretor of these substances. The difference from Bombay is that it is a secretor, para-Bombay is a secretor, and Bombay is a non-secretor. That is one secretion. Now what happens? The secretory substances, ABO, they get absorbed onto the RBCs. When this gets absorbed onto the RBCs, this is what is basically found in para-Bombays, which is, detected with very difficulty with the help of very robust testing like the absorption illusion. So as such, there is no antigens present on the RBCs, but rather they get absorbed from the secretion from a para-Bombay individual that we find out. So usually a para-Bombay, it presents as a group O in the forward grouping. So this is the basic behind it, that the secretion does have it, but the antigens on the RBCs are absent. So this is not such a poor fellow as compared to Bombay. So Bombay, lacking everything in red cells as well as secretions, develops anti-H because the antigens are not present anywhere in the body, neither in the secretions and neither on the RBCs. Whereas para-Bombay, it will not develop anti-H. Why? The reason being that at least its secretions has, or the organs, they do have these, expression of AB antigens on them. So hence it will not develop anti-H. It will develop anti-IH or some cold agglutinins, which we'll not venture into right now. We'll just talk about anti-H presence and absence in Bombays and para-Bombays. So far we have learned that we have two H deficient phenotypes, Bombay and para-Bombay, that we know about. The basic difference is a secretor and a non-secretor status, and the presence of anti-H in present and absence in either of the two. So far we are aware, and most of us are aware of this two types of phenotype. So moving forward, now keeping the basic concept in mind, now we move forward to the case what happened in our institute. So there was a patient who was a 64-year-old female who was admitted with the diagnosis of acute disseminated encephalomyelitis. Previous transfusion history, there was no blood transfusion or transplant in her, and the physical examination revealed pallor without icterus. Investigations showed that the hemoglobin was 5.8 grams per deciliter and the hematocrit was 16.2. There were no signs of hemolysis or diminished LDH or bilirubin. Nothing was observed as such. So what happened is that we received a request at our blood center for direct Coombs test and request for 2 units of PRBC in view of low hemoglobin. Moving forward, now what we do, normally this is the pre-transfusion testing protocol at any of the departments of transfusion medicine. Just like first we do the blood group confirmation, forward and reverse grouping. Now in case the blood group is confirmed, we proceed to step 2, which is the compatibility testing. What if the blood group is not confirmed? That means that the forward and the reverse grouping doesn't match. So then we do the immunohematological workup with the help of a fresh sample for blood group discrepancy resolution. Now here compatibility testing and cross match is done after this. What if it's compatible? We issue the blood unit after proper documentation. And if it is not compatible, moving forward, these are the steps that usually we follow as a protocol. For allo antibodies, we perform the DCT, ICT, and we give compatible antigen negative blood unit. Even if that is not done, then the maximum that we can do right now in the absence of molecular testing is that we give a minor blood group phenotype matched unit, which usually comes out to be compatible, right? So this is the normal protocol. Moving forward. Now what happened in this case? Firstly, the forward grouping was performed. You can see with anti-sera A, the reaction is 4+, then anti-sera B it is negative, and anti-D it is 3+ reaction. So clearly it is ARST positive blood group. In reverse grouping, what happened? We observed that just considering the A and B, it came out to be as O, but the O cell also turned out to be positive. So inference in this case was O blood group with O cell positivity so far. So it was the anti-H when we did was negative in this case, but A was 4+, so we assumed that there is a conversion of H. So we went forward with the type 4 blood group discrepancy in view of this reactivity, and we moved forward with the resolution of this. What was the reason? Then we went forward. We ruled out all the clerical, technical, or transcriptional errors, and the blood group was repeated with a fresh sample. And that too showed similar findings. So what we did was, we set the possibilities of a very high frequency alloantibody which was reacting, or there may be an autoantibody which may be present. So in order to resolve this, we performed a 3-cell, 11-cell panel. This 3-cell panel, we are not shown the picture, but 11-cell, you can see that there is a 4+ reaction in all the 11-cell panels, which was the case with 3-cell. If we did the 3-cell, we need not go to the 11-cell panel because it was shown that there was a pan reactivity, and the autoantibody was clearly negative in this case. So it rules out any autoantibody and an autoimmune cause of anemia for this patient. At least that was ruled out. Moving forward, we performed the direct Coombs test. Now this Coombs test was negative, hence it ruled out any immune-mediated hemolytic cause of anemia. As such, there were no signs of hemolysis, so that was already ruled out. And DCT was negative, but they demanded a DCT, so we just gave this weak positive or negative picture in this case. Moving forward, the compatibility test and cross-match performed was, we found many units all were 4+ incompatible in this case. So definitely there was some high frequency antibody, but as the patient required blood, the HP was low. We were getting calls, so we thought let's just see for the time being whether the sons were compatible or not. So we just took a chance on O and A blood group, but they were not compatible. Same findings. Siblings also, she was a 67-year-old female, so a younger sibling was 4+ incompatible, whereas the elder sibling was 2+ incompatible. But the sibling was 78 years old. We couldn't have actually done anything in that case, so we just went forward with it. Then moving forward, we actually tried a lot of blood units in this case, and all turned out to be 4+ incompatible. Even the children and the siblings were not working out for us. So we went forward. The next step that we could have think of was, we went with a minor phenotyping. Now we were lucky enough that we had all these anti-seras for minor phenotypes because we had a project going on for rare blood donor registry. So we made use of these anti-seras, and we have around 75 donors with their complete phenotype with us, O blood group donors. So this was the phenotype of the patient, and out of those 75, 2 donors were there who matched exactly with this patient's phenotype. But to our surprise, this also turned out to be 4+ incompatible. All the 2 donors whose phenotype completely matched with our patient turned out to be 4+ incompatible. Now in this case, we realized one more thing, that Lewis and UST both were negative. So as this is an indirect marker for saliva testing in this patient, we knew that our patient was a non-secretor. We couldn't perform the saliva test because the patient was disoriented in view of her diagnosis. So we know that the patient was a non-secretor, this patient. So moving forward, finally, meanwhile, what was happening with the patient? The patient was on conservative management. We utilized the first pillar of PBM, which says that optimizing one's own red cell mass. And the patient was put on erythropoietin, IV iron, vitamin B12 injections, and folic acid. So she was a regular this thing. Eventually, the patient improved symptomatically based on the diagnosis. That was cured, but her HB was still low. So being on conservative management, after a few days, she was discharged on an HB of around 6.97 because they were scared of any kind of, infections being acquired in the hospital. So she was a local, was staying near the hospital. So we had informed her, in case when the blood is ready, we will call you for a transfusion. Meanwhile, you keep taking the medicines, we'll call you on a daycare basis for the transfusion. So the patient was, that way she was discharged on 7.2 hemoglobin, 7.1 or something. So meanwhile, what was our approach? What did we do? We went forward. Now, what could have been the reason? Further immunohematology workup, our final inference till now was that there is some very high frequency antibody. Now, what is that antigen which is present in the most of the individuals, which is 99.9% prevalence, against which if the antibody develops, will lead to high frequency antibody. So what comes to our mind is anti-H. because we know 99.9% of us has that antigen, and against it only we'll have such a high frequency antibody. But anti-H, could it have been in this case? We were a little skeptical because anti-H was one of the diagnostic criteria for a Bombay phenotype, which this was not clearly not a Bombay, because it was an A blood group in the forward grouping. And secondly, when A antigen is present, so H has to be there at some point of time. So H has been converted into A antigen. That's why only it is giving a 4+ reaction in the forward grouping. So in that case, we were not thinking of those lines that it was an anti-H. So we kind of ruled it out because of the presence of 4+ reaction in the forward grouping. And moreover, second option, was it a para-Bombay? No, because it couldn't be a para-Bombay, because the antigen was easily detected in a conventional tube technique. Whereas in para-Bombay, we know that you require robust testing to elute the adsorbed antigen from the plasma, basically. So you'll have to do, whereas in our case, it was just a direct tube test to reveal the A antigen present in the forward grouping. And moreover, para-Bombays, they do not have anti-H in their this thing. So that was one para-Bombay. The para-Bombay, our patient was a non-secretor. So 2 reasons for ruling out para-Bombay: A antigen was easily detected, and second, our patient was a non-secretor, whereas para-Bombays are clear-cut secretors. Next, Bombay, definitely it was not a Bombay because the forward presented as A blood group. So all these options were ruled out. Moving forward, now the only resort that we had was, we even took a second opinion. We sent the sample to Medanta in Gurgaon, and we took a second opinion that whether are we missing something. So we performed, we send them the sample for, indirect aluminization. We send them the sample. The same findings were observed. So they were also suspecting a very high frequency antibody. So we went forward with sending the sample to IBGRL. So that is the International Blood Group Sample Laboratory. It is in Bristol for analysis and compatible blood unit. But before sending the sample, I dropped a mail and I asked Nicole, I sent all my findings, that these are the findings. So they will tell us whether we can send our sample or not. So finally they said, okay, you send the sample along with the sibling sample if at all it is present. So fine, we went ahead with it. We sent the patient sample as well as the sibling sample. So after some few days, we received the report. So this was the report that follows. The report said it is AH blood phenotype with a strong anti-H antibody present in the plasma. So now we started wondering, AH, but we know AH is a para-Bombay phenotype. That doesn't match. Moreover, anti-H antibody, if you're calling it a para-Bombays don't have anti-H antibodies in the plasma. And moreover, they also alloadsorbed, removed the anti-H, and beneath anti-B was found. So that is clear that the forward grouping was all right. Anti-B was there in the serum. So the forward grouping confirmed the presence of A antigen and the blood group was A, in short. So this raised a lot of questions. We were wondering what to do that AH, para-Bombay, and anti-H antibody, which we have ruled out. Because if A antigen is present, then H would have been there. And then when an antigen is present, how can a body develop antigen against the antibody against its own antigen? So finally, what we thought was, we began the brainstorming and I mailed back to Nicole as well. So we asked, how do we reduce the sample to be AH, so para-Bombay when? So our sample is A positive with simple tube test, while para-Bombays require robust testing like adsorption and elution first. And para-Bombays, they do not have anti-H antibodies. And I even gave the reference because I was confused and we were wondering what could be the reason. So Nicole was kind enough. She replied to that. She said, we do not consider the AH as a para-Bombay group. It's like, okay, this is new that we do not consider AH as a para-Bombay group. Second, she mentioned that it was a partially H deficient antigen to convert. Partially H deficient or something is there. And she even sent me, she said that please consider the screenshot. Now this is the screenshot that came from her side. It was Job Daniel, the book that we all are very much aware, and it has clearly mentioned this, H partially deficient, non-secretor, and this is the notations being used for them. Whereas the notations for para-Bombays are different, which mentions it as OH secretor. So we'll discuss this later in a few slides ahead. So this was what. So now I was wondering if something is there in the book, eventually there will be something there in the literature. So after extensive literature search, we got hold of an article in 1961. It referred to AH and incomplete suppression of A resembling OH. So now there is interesting because when these H deficient phenotypes, when they were being discovered, they were referred to as the suppression of particular antigen. Suppose H is absent, that means H is suppressed. That time the concept of mutation was still in the forming. They used to mention as suppression. This is something that was close to what we found, but this was a secretor. Then moving forward, I came across this literature in 1982. It referred to as H-deficient blood group, Bombay of the Reunion Island. And now what these 42 H-deficient individual findings were exactly similar to the findings that I had in my patient. What were the findings? Anti-H was present, according to the report that we got from IGBRL. And second, A or B antigens were clearly, expressing on the forward grouping. And plus, they all were non-secretors. Now, these were the findings that were being collaborating with the findings of our case. So moving forward, I went ahead in this literature. This showed this picture. So this is interesting because according to the chronology, in 1952, H-deficient phenotypes were described first in the Bombay in 1952 by Dr. Y.M. Bhende. It was discovered here in Bombay, we can see. Then next in 1981, this South African province of Natal, here too, 12 H-deficient pedigrees with the Bombay blood type was found, but this community was also Indian. So probably this was a migrated community which was found here in 1981. Now third, in 1982, this was the Reunion Island in the Indian Ocean next to the Madagascar. Here, these 42 individuals, not so similar like the Bombay or the para-Bombay, these individuals lacked the H antigen but contained the A or B antigens with an anti-H antibody in their antisera, and they were found on these Reunion Islands. So this was what was found here, and after this has not been reported yet. But after there is nothing on these reunion types, and as they were not matching with the Bombays or the para-Bombays, they just refer to them as the reunion type, resembling the Bombays, something like that. So one interesting fact about this island was that initially in the 17th century, it was occupied by the French people. So that time, just to deviate a little, French people, and they had these Africans working for them into their deplantation fields. But when they got their independence in 1848, they recruited Indians to work for these fields in this Reunion Island in the 18th century by the French. So somehow it is even intercepted that maybe the ancestry, way back, it could have been some Indian ancestors that led to these different phenotypes, because, Indian land is kind of pioneers in this H-deficient phenotypes. Anyways, it was not proved later, but this was what they found. After this, it was not discovered. After this, it is not reported, these kind of findings. Now, there must be other reasons. So finally, we come to this conclusion that H-deficient blood group phenotypes, apart from Bombay and the para-Bombay, that we already know. Bombay and para-Bombay are H-deficient phenotypes. Bombay is a non-secretor, para-Bombay is a secretor. But this reunion type, it is partially deficient and is a non-secretor. Partially deficient means it has some, as was told by Nicole as well, partially deficient means some H was expressed due to a mutation only, but that got completely converted into A or B antigens. Hence, we had the H negative. And because there was a mutation, and because there was a partial deficiency of H, that led to the development of these anti-H antibodies in these individuals. And what is the main thing that we are doing is that OH of the reunion, this notation belongs to this phenotype as per Giordano's, and also, but what we are doing, what the literature in India as well as outside India, what is happening is that we are using it for para-Bombay. So that's why the entire confusion arose, that when I got the report, I got confused. It was mentioned as AH, but AH we usually use it for para-Bombays, but para-Bombays don't have all the features that was coming in this case. So that was clarified. So finally, we realized that this is the notation that is causing a problem. And we are finding para-Bombays, but we are writing them as AHBS, hence we are getting confused. So ideally, Bombays and para-Bombays, the notations are like this, and para-Bombays being secretors, you just put a dash and you write secretors there. Both Bombays and the reunion type will have anti-H antibody. Okay? Because they don't have H, they have mutated H in their antibody, and here para-Bombays will have anti-IH antibodies, which is a cold agglutinin, probably mostly clinically insignificant. So only compatible units for reunion types and Bombay would be Bombay phenotypes only, or the same blood group, whereas para-Bombays can work with others depending on the clinical amplitude and the clinical significance as well. So here we realize that this was the mistake that we are doing. So let's see, we can see various literature, para-Bombay AH, AH para-Bombay, para-Bombay BH. This BH para Bombay. These are all the literatures that, para Bombay BH has been mentioned. So to conclude, we come to this conclusion that H partially deficient, non-secretor AH blood group phenotype, like the reunion, and unlike a Bombay or a para Bombay. So this was our finding finally that we concluded. So moving forward, this got published in the Transfusion and Apheresis Sciences journal. And here I specifically mentioned the differences between three with the reference of obviously Geoff Daniels, and there is another applied blood group serology textbook, a wonderful textbook for making our concepts very clear. The secretory status, the red cell findings, and the absorption and elution findings and notations that we use thereof. One more thing I did was I devised an algorithm. Now this algorithm contains all the three tests, that is red cell test, serum test, and the saliva test. Now these red cell tests, how to proceed step by step, we'll come to know by following these. We know which we are coming based on our results. Similarly, the serum, the type of antibodies that we are suspecting, anti-H, anti-IS, and these differentiating factors using the cord cells, Bombay RBCs, and adult O cells, we can make use of this to derive what kind of antibodies are there. And finally, the saliva testing. Non-secretors would probably fall into H partially deficient or H completely deficient non-secretors, these two. And if it is a secretor, it will probably pass into a para Bombay phenotype, which is H deficient, complete H deficient secretors. So here is how you making use of this algorithm, we can actually find out which H deficient phenotype we are dealing with. Moving forward, this was selected as a poster. Definitely, I got a travel grant for the same to present my work in ISBT Gothenburg. Then recently, we found a normal Bombay also, a 18-year-old first-time donor. We found, we went on a camp, and then this first-time donor turned out to be a Bombay. Now, this is the notation that we use, tested at our blood center. So acknowledgements would be, first the summary, I would just say that anti-H must be included in routine testing because we never know how many H partially deficient phenotypes we may have missed. It only got caught because the antibody was there and it was so strong, but we don't know, we may have been missing. Second, in order to find the Bombays, these H deficient phenotypes, O cell in the reverse is very important. O cell in the reverse grouping, and plus or either an ICT. If we miss these, don't perform a O cell or ICT, we are definitely going to report them as O blood group based on the Bombay. And to be very honest, the reverse grouping in our automation and our gel cards do not have O cells. They only have A, anti-A and anti-B, and one control is there, and A cell and B cell is there. So O cell we are not using in our gel cards also. In most of the companies, ours we don't have. So we mandatorily perform ICT to order to find out whether there is, any indirect antibody present or not. So this is two things that we learned, that anti-H and reverse grouping O cell or ICT should be done for all patients and donors in order to not miss out such phenotypes, which have more propensity to be found in India. So lastly, my acknowledgement obviously to IBGRL Nicole Thornton for helping me with finding out what was happening in this patient. My respected seniors in AIMS who helped us to send samples to IBGRL, how to send it and all those works. The entire department who helped me for supporting. Department of Neurology for showing so much of patience, because at the end clinicians do want blood for the patient and for that matter. Then serve for travel grant to present my work here. So thank you all. The take home messages. If you really want to do something, you'll find a way. If you don't, then you'll find an excuse. So thank you all for your kind attention and patience. So this Reunion Island turned out to be a very beautiful place, which I Googled. It is actually present very in for Instagram followers these days for hiking. It's a beautiful place if anyone of you wants to go and have a look. So thank you all for your kind attention. I'm happy to take any questions. Thank you.
Thank you, Jaswashree, for the excellent presentation. So we need to visit the Reunion Island.
Yes, sir, for sure.
So our next speaker will be Dr. Deep. So Dr. Deep, you can start and we can take the question at the end of the session.
Thank you, Dr. Subro. I have just started my screen sharing. Is it visible in full screen?
Yes, it is visible.
1 minute. Okay. Good afternoon, everyone. I'll be presenting my research study, which I presented at ISBT Congress, Gothenburg. I'd like to thank Transfusion Medicine Academic Society for giving me this opportunity. So, my research study was titled Ironing Out the Risk, Assessing the Effect of Platelet Pheresis Donation Frequency on Iron Stores in South Asian Male Donors. And I'm currently working at Kasturba Medical College, but this study was conducted at my previous workplace, that is ACTRAC, Mumbai. So, the overview, these are the topics that I will be covering in this presentation. And first, we'll discuss the background. So, we all know that donation-induced iron deficiency is an established phenomenon among blood donors with an increasing recognition in poor resource settings. Now, published literature confirms that regular blood donors experience a progressive decline in iron reserves as the frequency of donation increases, and this often lags with the decline in hemoglobin. This is well illustrated in this publication, wherein if you see with normal iron levels, the hemoglobin is normal. But when iron depletion starts setting in, the iron depletion is ahead of the hemoglobin. So hemoglobin remains normal when it is depleted, and even when there is iron deficient erythropoiesis, the hemoglobin is still in the normal range. It is only in the iron deficiency anemia when the body iron stores are completely depleted that the hemoglobin will drop to a level that is detected, and you can call it low. So we know across the world there are different cutoffs for low hemoglobin. There are some countries which have different cutoffs for males and females, and even the values which are used to determine ferritin as low is varied. They might be 30, 20, or 15 in some countries. And this also determines the duration of deferral and repeat testing policy for such donors. And AABB has suggested various strategies to reduce the risk of iron deficiency among blood donors, such as increasing the interdonation interval, ferritin testing, and iron supplementation. The problem statement why we want to conduct this study was apheresis donors, they are known to lose fewer RBCs than whole blood donors, but they may be at risk of iron depletion because of the higher donation frequency, that is 24 times a year, and chronic small volume red cell losses, which would be to the tune of 50 to 80 ml per procedure. Because every time we'll be taking the samples for TTI testing, and there will be residual amount of blood, as you can see in the kit. There's so much amount of tubing. This is just the Optia kit. The Amicus kit, there are a lot many more tubings in which the blood remains present. So in India, this remains a particularly important topic for discussion because we have an inherently higher prevalence of iron deficiency. And as per an article, platelet donors could even experience losses of up to 2 to 2.4 liters if they were donating at the maximum allowable frequency of 24 times per year. This is whole blood loss, not a red cell loss. So concurrently, the red cells would also be depleted at a much higher rate. So the objectives of our study was to study the variation in the hematological and biochemical parameters among repeat platelet donors, particularly concerning the iron reserves, to evaluate the correlation of donor iron status with frequency of donations, both recent and lifetime, compare the different indices using ferritin as a reference standard. And this was the best assay available at our institute, although now SCFR is being considered as a better assay. So we use this to ascertain economical alternatives for identifying iron depletion via ROC curve analysis. And we also estimated other dietary nutrients like vitamin B12 and folate to provide insight into the nutritional status of the donors. This study was funded through by the ISBT through the iTride program. It is an initiative of the ISBT Academy, and it is a two-part program. Part one deals with study design and protocol development, which is completed. And part two is training and analysis of data and manuscript preparation, yet to start because they don't have sufficient number of people who have completed their projects. So selected into the program for the research idea. And this program provides support in the form of developing a complete research protocol, exploring different study types, and you have individual guidance from two different mentors. And complete protocol was ready at the end of the program, and it was selected in the competitive grant funding for 5,000 euros. This study protocol is further reviewed by ACTRAC faculty, and ethical clearance was obtained. And ISBT also provided support and mentorship right through project implementation to publication. So methods, it was a single center study, observational study performed in the Department of Transfusion Medicine, ACTRAC, Mumbai. A total of 150 repeat donors and 30 first-time donors were recruited in the study when they presented for their platelet donation. The repeat donors were further enrolled into two equal groups, that is, infrequent donors, RID, who had 6 to 11 platelet donations in the last 1 year, and frequent donors, RFD, those who had more than 12 donations in the last 1 year. Informed consent was obtained and a structured enrollment questionnaire was administered to eligible donors, which collected data related to their platelet donation history, smoking, dietary, and medication or supplement history. And the blood samples for the test were collected from the sample pouch attached to the kit. CBC, reticulocyte indices, iron indices, and vitamin B12 and folate were performed by the hospital laboratory. Coming to our results, we achieved the target enrollment through purposive sampling, that is 180 total donors, 30 in the first-time donor group, 75 in the infrequent donor, and 75 in the infrequent, and 75 in the frequent donor group. Majority of the donors in the infrequent group were in the age group of 18 to 45 years, whereas majority in the frequent group, they were in the 31 to 60 years of age group. Among the infrequent donors, non-vegetarians were more common, whereas vegetarian preferences were more common among the frequent donors. And in the medical history, what was important was that only 2 donors out of a total of 180 reported taking iron supplementation, whereas about 11 donors gave a history of vitamin supplementation. Coming to the donation history among repeat donors, this basically gives the deferral due to low HB. If yes, then the number of times that they were deferred, and the lowest historical HB if they had track of that. So what we found was most significant finding was only 4% of the donors out of 75 were deferred in the infrequent group, whereas about 29.3% of donors were deferred who were in the frequent group. And a majority of the donors who had been deferred in the frequent donor group were about 1 to 4 times, but there were about 4% of donors who were deferred even up to 10 times in their donation career, with one donor being deferred up to 14 times. Coming to the serum ferritin-based classification of the donors, we classified the donors in the different groups based on their serum ferritin levels. So any donor who had HB more than 13 and serum ferritin more than 30 was considered as iron replete, represented by the blue color. Those who had serum ferritin between 15 and 30 were classified as low ferritin, represented by the orange color. And those who had serum ferritin less than 15 were classified, but HB more than 13 gram per deciliter were donors with absent iron stores, represented by the gray color. If HB was less than 13, as per WHO classification of anemia, they are classified as having iron deficiency anemia. So that is represented by the yellow. What we can observe is that the proportion of individuals with iron replete status keeps on decreasing as the frequency of donation increases. So in the first-time donors, it was 67%. Among the infrequent donors, it was 61%, and it was only 21% in the frequent donors. That is, those who had more than 12 donations in the last 1 year. These people, on the other hand, had a highest proportion of individuals with low ferritin and absent iron stores, with 41% of individuals with low ferritin and 27% of individuals with absent iron stores. Again, the donors with low ferritin values were higher in the infrequent group as compared to the first-time donors. We also had some individuals who had HB between 12.5 and 13, and who would be actually classified as being iron deficient as per the WHO classification. Coming to the correlation coefficients of hematological and iron indices with lifetime and recent donations. These correlations show that the hematological indices do not change significantly with increasing number of donations, especially if you see with respect to lifetime donations. All these marked with the star are non-significant correlations. On the other hand, if you see all the iron indices, all of them correlated significantly and in a negative way with lifetime and recent donation, with serum ferritin showing the strongest negative correlation at -0.346. This contributes evidence that hematological parameters are incapable of accurately reflecting iron status, and iron status testing is thus recommended even in platelet donors. Coming to intergroup comparisons, we had 3 donor groups and we wanted to compare the hematological and biochemical parameters across the 3 groups. So we performed a one-way ANOVA test, so followed by the pairwise comparison of means using Tukey's HST post-hoc analysis. What we found was between the first-time donors and the frequent donor groups, there was a significant difference in means for ferritin and TIBC. So in this figure, what we are looking at is the first-time donors and the frequent donors, which was lower in the case of ferritin, and TIBC, which was higher between the 2 groups. But when we compared the first time with the infrequent donor groups, these two, there was not much significant difference in the means for both ferritin as well as TIBC. Among the repeat donor groups, when we compared the parameters, we found a higher red cell distribution with lower HB, ferritin, and iron and transferrin saturation among the frequent donor group. These are the box plot representation of the same. So the first one is the infrequent donors, and the second one is the frequent donors. So this show a significantly lower ferritin level, significantly higher red cell distribution width. And here we have the box plots for hemoglobin and serum iron, which are lower in the frequent donors. And this was a statistically significant difference in the means. Coming to the performance metrics, the aim of this analysis was to identify economically viable alternatives that may be used as an initial screening test to guide selective ferritin testing, since we may not be able to test all the platelet donors for their iron levels. Our results showed that several of the tested indices show good sensitivity and specificity, especially at serum ferritin level less than 15 nanogram per ml. Now, this selective testing would yield a higher detection of iron depleted donors and would also be a cost-effective strategy in poor resource settings. In our analysis, we found that transferrin saturation showed one of the best diagnostic probabilities, followed by iron and TIBC. And I'll be discussing why this is important in the discussion later on. Coming to ROC curve analysis, when we compared recent donations with serum ferritin, we found that donors with more than 11 donations had a higher probability of having a ferritin level below 30 nanogram per ml, with a sensitivity and specificity of 62 and 82% respectively. Coming to discussion, we know that the eligibility for blood donation is usually tested using hemoglobin because it is available as a point of care test. But it is established in several studies that hemoglobin is a poor indicator of iron status, as may not decline till the iron stores are completely depleted. Now, the current hemoglobin cutoff of 12.5 gram per deciliter may serve to prevent anemia, but does not accurately mitigate development of iron deficiency. So overall, in our study, we found a higher prevalence of iron deficiency as compared to previously published data, which probably represented Western donor characteristics. About 53% of total participants showed either low or absent iron stores, with greater prevalence among the repeat donors, especially the frequent donors. These findings align with previous studies by Page et al. And Dugan et al., which showed that repeat platelet donations could result in decreased ferritin levels and iron deficiency. Further, 16.7 and 10% of donors showed low ferritin and absent iron stores even among first-time donors, which shows that they already had low iron stores at the start of their donation career, whilst their hemoglobin levels allowed them to donate, even though it was in the normal range. And donors in the study were intimated when the serum ferritin levels were less than 30 nanogram per ml and were advised dietary changes such as iron-rich foods or a physician's visit if they wanted to consider iron supplementation. We also recommended halting platelet donations for 2 to 3 months and retesting of their ferritin levels before they return for donation. But this was not followed up in our study as such. The history for deferral of low HB among our participants was interesting finding because higher proportion of such donors were found in the frequent donor group, with majority of the donors being deferred about 1 to 4 times in the donor career. And we found a lower proportion of iron replete status in vegetarian individuals. And even though there were some non-vegetarian people who had low ferritin and absent iron stores, which suggests that genetic environmental factors may be contributory for developing iron deficiency in the region. And inherently, such nutritional anemias are more common within the Asian subcontinent. Yeah, we saw a significant negative correlation of ferritin with both recent and lifetime donations, so consistent with other studies reporting increased iron depletion with higher frequency of donation. And another correlation that we tested was the one between ferritin and platelet count, which was insignificant, in contrast to another study which reported a significant negative correlation. Thrombocytosis seen in individuals with iron deficiency anemia could be an exaggerated response in anemic individuals that was probably not replicated to the same extent in individuals with non-anemic iron deficiency. So our results from the pair intergroup comparisons were similar to previous studies, which reported lower values of iron indices among repeat donors. Using detailed ROC analysis, we derived the optimal cutoff values for different parameters with their sensitivity and specificity. Since serum ferritin monitoring strategies for the entire donor pool is prohibitively expensive, these cost-effective assays could be of utility as a screening technique in resource-poor settings for identifying donors who may benefit from targeted serum ferritin testing. Now, during the ROC analysis, we found that transferrin saturation, which is actually a calculated value obtained from serum iron divided by TIBC into 100. These three values are actually quite helpful because they are a very cost-effective alternative to serum ferritin testing. It was almost 10 times lower if we did all. If we got three values instead of doing the serum ferritin testing. So that's something that we can explore in the future at other resource-poor centers as well. And in the absence of consensus ferritin level and variation in the sensitivity of assays, a ferritin level less than 30 should be targeted because these are altruistic individuals who are donating, and we are not diagnosing iron deficiency in them as patients. Lastly, coming to the strengths and limitations of a study, the strength are uniform enrollment of donors based on recent donations, which allowed for accurate correlation between iron status and donation frequency. Good evidence that cost-effective tests could be used as an alternative to serum ferritin, and we also provide the optimal cutoff values for these tests, which the blood centers in resource-poor regions can use to develop a cost-effective intervention model. And we studied vitamin B12 and folate levels to look into the nutritional status of the donors, but they were mostly found to be normal. Coming to the limitations, there was donor heterogeneity with respect to the lifetime donations, and we did not follow up their serum ferritin values for further depletion or recovery of iron stores. We were limited by the total pool of voluntary donors, which meant matching for age, BMI, medical history was not feasible during study enrollment. And the unavailability of a centralized blood donor registry made it unfeasible to acquire any whole blood donation history prior to enrolling as a platelet donor. Coming to the conclusion, repeat platelet pheresis donors may often sustain their hemoglobin, hematocrit, and RBC count to remain eligible for donation, but are usually unaware of their diminished body iron reserves. Nominal blood loss during mandatory infectious disease testing and in the disposable plastic systems, hemolysis during apheresis seem to be the primary cause of decreased HB and ferritin level in apheresis donors. And the present allowable frequency of donation, that is 24 times per year, may not be feasible to maintain body iron stores as a result of genetic, environmental, and dietary factors in our population. So blood centers must regularly monitor frequent donors, especially those with more than 11 donations in the calendar year, and maintain their serum ferritin levels above 30 nanogram per ml. And larger prospective studies among apheresis donors are recommended to understand the iron depletion kinetics. Coming to my acknowledgements, I would like to thank ISBT for the educational opportunity as well as the generous research grant. We would like to thank all our voluntary platelet donors who participated in the study. I also extend my gratitude to the faculty in ACTREC Mumbai, Dr. Sumati, Dr. Shashank Oja, Dr. Preeti Chavan, and staff in the Department of Transfusion Medicine ACTREC for their guidance and inputs in the research broader and conduct of the study. And a special thanks to Dr. Jennifer Mendes and Dr. Shamisha Asri for contributing to data analysis, clinical interpretation, and manuscript compilation and publication. Glad to share that the article has been accepted in Vox on 17th of August and is currently in post-production. So it should be available soon on the journal website. So these were my references, and thank you, everyone. I'll be happy to take any questions if you have.
Thanks, Dr. Deep, for the excellent presentation, and congratulations for acceptance of your manuscript.
Thank you. Thank you, sir.
So I will take few questions which are present in the chat box. So I think a question to Dr. Jaswashree that can you please explain the mechanism by which the anti-H developed in a partial or weak H patient?
The mechanism by which it developed. Hello, am I audible?
Yes, 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 absolutely.
Probably we can just compare it to something. There is mechanism can be compared to like the weak D or partial D. We have anti-Ds in those cases. Maybe it is something like that which is developed. That partially it was present initially, some amount of it, which led to the development of the antibody, and rest of it got converted into the further A antigen or B antigen. That is what that could have been explained in these cases, because others don't have. This has, but it is a mutated form of that H antigen, which some of it got converted and some of it is still was remaining on the RBCs initially, which led to the development of antibodies. Because usually normal antigens, we don't develop antibodies against. It's the mutated antigens or the external antigens by which we develop antibodies against. So that is the maximum that we can think of in this case.
Did they perform any, if you do one or two sequencing the molecular?
No,
part?
sir, no. That was what was missing. Actually, I asked them to do the molecular typing also, but by that time, the response was not there, because molecular initially we just sent the sample for detection of the high frequency antibody and the this compatible blood unit. So that results were here. The molecular typing results were not shared with us. I repeatedly mailed them again that if that could be shared, it would help. At least we would know that whether it's matching with any of the known mutations in the Bombays or para-Bombays, but that is not shared.
I think that could actually explain the mechanism.
Yes, sir. Yes, sir.
Taking that particular mutations.
Yes, I agree, sir.
Hello, Dr. Deep. Hello, Dr. Deep. Am I audible?
Yes, absolutely.
Okay, Dr. Deep, I am Dr. Sabin from TMH. So I just wanted to ask a question about the RFD donors, random frequent donors. Is vegetarianism statistically significantly correlated with the serum ferritin levels in the second group? Is it like that vegetarianism and serum ferritin levels are correlated statistically?
No, we did that test, but they were not those correlations were not statistically significant.
And
so diet was not although we had the differences, we had slight differences in the groups, but the effects were not found to be statistically significant.
Okay, so in a resource poor setting, as you said, in the hematological parameters are not as good as the iron status testing for detecting the serum. The iron deficiency status. So, which do you think which among the indices would be the most appropriate one for a resource poor setting in common apheresis platelet pheresis centers in India in South Asian population?
I didn't get your question exactly. Could you please repeat?
So you told that hematological parameters, other than the iron status testing, which would be more useful for the resource poor setting parameters. Everyone cannot test serum ferritin levels, right? So in CBC, can we detect some hematological parameters like TIBC or iron saturation, which will be helpful?
And TIBC and saturation are iron indices. Those
Yeah.
are actually better in the sense they are cost effective as compared to ferritin.
Okay.
So those can be explored, iron and TIBC, because if you use iron and TIBC, at our center at least it is about 10 times a lower cost, and you also get a
Okay.
third parameter which is transferrin saturation. And you could even like combine two or three of them and decide for the donors. If not
So
stopping the donations, you can definitely request them to take a longer gap.
okay.
Between
One
subsequent
more question
donations.
is there. Is the racial and minoritical factors there? Means how you did your population study in South Asian population, right? So
Hmm.
does the race affect the correlation coefficient or something in the ROC curve? Did you check that?
Actually, this was only done in Indian population, so racial and all not be able to
Did you
comment.
find any
In general,
literature or anything like that? Literature finding that Caucasians or whites have the same similarity with the say study set, or it is confined to in Indian population itself?
in Western populations of Caucasians, what we saw is whatever studies have been done, they had a lower prevalence. They did have iron depletion, but it was only to the tune of around 20 to 30%. So
Okay,
in our study, we found a higher, almost about 53% of total participants having low or absent iron stores.
okay,
Definitely there are racial, ethnic differences, and that could be because nutritional anemias are more prevalent in the Asian subcontinent. So, and we
okay.
fall in that Asian belt. Yeah.
So, do
So,
you think any nationwide policy should be formed for the iron serum testing in platelet pheresis donors in India? Do you feel like any nationwide policies for platelet pheresis or this testing should be done for iron
um,
status?
I think before going ahead with platelet pheresis, we should have it for blood donors first. But we can definitely
Okay,
think about maybe reducing the donation frequency, because I think it's in Scotland or Ireland. I'm not sure. They have decreased the frequency on their own to 18 per year. They don't follow
okay,
24 per year. So,
okay.
yeah, that was in one of the publications. So that is something that
So,
we can, I think that would be much more cost effective, lengthening the interdonation interval than mandating serum ferritin testing.
So any more question?
Sir, I have one question to Dr. Yashashvi.
Please go ahead.
Yeah, as you mentioned, the AH is called as reunion phenotype. Is there any particular specific name for BH?
These are just, hi Bala, these are just referred to as the reunion type AH. It's the same. I mean, if you detect A on the RBC, then AH. If there is B, there is BH. These are the reunion types as a blanket term for all of them.
So both AH
It's
and BH.
reunion BH. BH, even for that matter, ABH and OH, then you have to mention in this thing, because OH would, mix with Bombays and para Bombays. But with that, you had a superscript of H also with Bombay and para Bombay. Here, the superscript won't be there. It will just be a subscript OH. So whenever H is only in the subscript, it will be meant for the, partially deficient phenotypes also only.
Okay. Was this patient transfused?
No, it is not required.
Okay.
Later.
Yeah.
It is not, because we had a talk with some people that, we need a Bombay. So we inquired from other states, because right now, till now, our state didn't have. So we asked from other places, we arranged, but then the transfusion was anyways not required.
Yeah.
So now we just have one Bombay from our this thing. So it's fine.
Okay. But however, you got one compatible from the siblings, right?
No. It was 2+. It was 2+. It was not compatible. It was 2+ incompatible.
Okay, fine. So there was no this reunion phenotype in siblings or in next generation also, right?
No. It was all clear-cut A-O. There was no such phenotype in any of the siblings or the children. 5 children were there.
Thank you.
Okay.
Any more question to Dr. Deep or Dr. Jashashi? I think if there is no such question, we can end the session. So thanks to both of the speakers for the excellent presentation. And we got a lot of new information from both of them. And congratulations for the publications to both of the speakers. Thanks for my side. And over to you, Rofi.
Yeah, thank you, Dr. Subro, for sharing this very interesting session. We had an opportunity to hear two international, Indian speakers talking, who had presented their work internationally, and talk to us. Like we had around 90 participants during the peak time. Then I would like to thank Dr. Yashasvi and Dr. Deep also in taking their time for presenting their sessions. Thank you. And last but not the least, happy Onam to all of us, to all who have joined. Next week we have that, and we'll be joining next month with our second session of Team India at ISBT Gothenburg. Details will be forwarded in the website and also in our social media pages. So thank you. Thank you, everyone.
Thank you.
Thank you so much.